Welcome back to the deep dive. Today, we're taking what I'd call the ultimate shortcut into a really critical area of health.
We certainly are.
Our mission is to tackle the pharmacology of the lower respiratory tract. We're going to break down the drugs that fight obstructive diseases, asthma, COPD, and even some specialized conditions like RDS in newborns.
And when we say obstruction in those lower airways, we're really talking about the bronchial tree and the alveoli.
Right.
And the problem is fundamentally one of two things. Either you have inflammation and swelling that's narrowing the airway from the inside,
Okay.
or the muscles around the airway are constricting and squeezing the tube shut.
So because of that, the entire treatment strategy is built on, what, a two-pronged attack?
Exactly. We either have to achieve bronchodilation, basically open that air path back up, or we use anti-inflammatory agents for more long-term control.
We're going to tackle those two goals in order then. We'll start with the three main classes for bronchodilation, the Xanthines, Sympathomimetics, and Anticholinergics, and then we'll pivot to the drugs that handle inflammation.
Sounds like a plan.
And get ready to hit the red alert button, because some of these drugs have safety profiles that demand constant attention. Let's start with the Xanthines, a hysterical class, but definitely not for the faint of heart.
No, not at all. Xanthines, and theophylline is our main prototype here, are fascinating. They're one of the oldest treatments we have.
And how do they work?
Their mechanism is pretty unique. They directly relax the smooth muscle that lines the bronchi and the pulmonary blood vessels.
So that opens things up.
It opens things right up, which increases what we call vital capacity. And for someone in bronchospasm, that's huge. What's also neat is they have a minor anti-inflammatory effect, too.
Oh, really?
Yeah, they inhibit the release of certain chemicals that drive allergic reactions, which helps quiet things down a bit.
Okay, so if they have this dual-action bronchodilation and a little anti-inflammatory kick, why aren't they the first choice today? This is where that safety challenge comes in, right?
This is exactly it. It all boils down to a really a deadly game of numbers. Theophylline has one of the narrowest margins of safety in all of pharmacology.
How narrow are we talking?
Its therapeutic window is tiny, just 10 to 20 micrograms per milliliter. Below 10, it's not doing anything.
And above 20.
The second you creep past 20, the adverse effects are predictable and they come on fast. You start with GI upset, tachycardia. But if those levels hit, say, 35, you're risking seizures, irreversible brain damage, and even death.
Wow. So monitoring their blood levels it's just non-negotiable.
Absolutely. And this leads to a really surprising clinical trap, the interaction with cigarette smoke. This is the aha moment.
Okay, I'm listening.
So the chemicals in cigarettes are what we call enzyme inducers. They dramatically speed up how the liver metabolizes xanthines.
So chronic smoker's body is just burning through the drug way faster than a non-smoker's.
Exactly. Which means they need a much higher dose of theophylline just to stay in that safe 10 to 20 range.
I see the problem already. What happens if they quit smoking?
That's the clinical dilemma. If that chronic smoker suddenly quits, or even just cuts back a lot, their liver metabolism slams on the brakes. The drug isn't being cleared anymore. It accumulates.
So a positive lifestyle change, quitting smoking, could actually cause immediate severe toxicity if their dose isn't changed.
Precisely. All of a sudden, they're dizzy, nauseous, confused, having dangerous heart palpitations because their effective drug dose has just skyrocketed.
The nursing implication there is huge. You have to counsel them that any change in smoking habits means they need immediate blood work.
Immediate blood work and a dose adjustment. It's critical.
Okay, so to sum up the nursing pearls for theophylline: frequent serum monitoring, keep the dosing routine consistent, always with food or always without, but never switch it up.
Right.
And tell them to cut out other xanthines, like a lot of caffeine, which just adds to the risk.
You've got it.
All right, let's pivot to the second pillar, and maybe the most famous one, the Sympathomimetics. These are the rescue inhalers everyone thinks of.
Yes, drugs like albuterol and epinephrine. They mimic the effect of our sympathetic nervous system, our fight-or-flight response.
So they turn everything on.
They do. When you stimulate those receptors, you get immediate bronchodilation, and your breathing rate and depth increases. Albuterol is great because it's highly beta-2 selective, so it's mainly targeting the receptors in the bronchi.
But I'm guessing if you use too much, that selectivity kind of disappears.
It's lost at high doses, exactly. And that's when you feel that full systemic sympathetic cascade.
What does that feel like for a patient?
That's the classic side effects. Increased heart rate, feeling anxious or jittery, a noticeable jump in blood pressure. the body's diverting resources.
And epinephrine is the non-selective version of that.
It's the ultimate version. It hits all the sympathetic receptors, making it the prototype and the go-to drug for acute life-threatening bronchospasm, like an anaphylaxis. It is incredibly fast and powerful.
Speaking of life or death, we have to talk about the major safety alert with the long-acting beta-agonists, the LABAs, like salmeterol.
Yes. This is a non-negotiable teaching point. LABAs carry a black box warning from the FDA.
Why is that?
Because their use has been linked to an increased risk of asthma-related deaths, and that risk is especially noted in older patients and in African-American patients.
So what's the rule now?
The rule is strict. LABAs must never be used alone for asthma maintenance. They have to be combined with an inhaled corticosteroid. Always.
And crucially, even though they're bronchodilators, they are not rescue drugs.
Exactly right. They're maintenance drugs. They're for prophylaxis, long-term control, because they act much more slowly. Using one during an acute attack is not only ineffective, it's dangerous.
So for implementation, say for exercise-induced asthma, what's the tip?
You teach the patient to use their inhaled sympathomimetic about 30 to 60 minutes before they start exercising. That ensures the drug is at its peak effect during the activity.
That makes perfect sense. Okay, pillar number 3, the anticholinergics. These are the alternatives, like papratropium.
So instead of turning the sympathetic system on, these work by turning the parasympathetic system off.
So they work on the other side of the nervous system.
Think of it this way. The vagal nerve is always putting a subtle brake on our airways, using the neurotransmitter acetylcholine.
Okay.
Anticholinergics just block that acetylcholine. By taking the foot off the brake, the smooth muscle relaxes and you get bronchodilation.
So they're less potent than the sympathomimetics,
But they are vital for patients who can't handle the cardiovascular side effects of the adrenergic drugs.
and because they have those systemic atropine-like effects, there are some important contraindications. What do we need to watch out for?
Well, you have to be careful with any condition that's aggravated by decreasing smooth muscle tone. The two big ones are narrow-angle glaucoma.
Right, because of the eye pressure.
Exactly. It can dangerously increase intraocular pressure. And the other is prostate issues. For men with bladder neck obstruction or prostatic hypertrophy, these drugs can make it very difficult to urinate, leading to retention.
And the common side effects follow that same logic. Dry mouth, sore throat, maybe some dizziness.
You've got it.
Okay, so we've opened the airways. Now let's hit that second major goal, decreasing the inflammation and swelling. This is really the key to long-term management.
Absolutely. We're moving from rescue to maintenance now, and our first line here are the inhaled steroids, with budesonide as a great example.
How do they work?
They just decrease the overall inflammatory response in the airways. Over weeks, this leads to increased airflow and makes the airways less hyperreactive.
Weeks, you said. That seems like a key safety and adherence point. How long does it actually take for them to work?
This requires a lot of patient teaching. They take a long time, 2 to 3 weeks, to reach effective levels. A patient expecting immediate relief is going to give up. They are purely for maintenance. They do absolutely nothing during an acute attack.
And since they're delivered locally, right into the throat and lungs, they have their own set of local side effects.
They do. We often see a sore throat, hoarseness, and the one everyone worries about, oral thrush, a fungal infection.
So what's the single most important piece of advice to prevent that?
The patient must rinse their mouth thoroughly with water after every single use. Every time. It washes away the local drug residue and also decreases how much gets absorbed into the rest of the body.
Okay. And what about our second anti-inflammatory class, the leukotriene receptor antagonists? Zafirlukast is the prototype here.
Right. So these are more targeted. We talked about chemical mediators that drive inflammation and bronchoconstriction. Well, these drugs selectively block the receptors for those specific mediators.
So they're blocking the inflammatory signal before it can even start the cascade.
That's a perfect way to put it. They prevent the swelling and tightening from happening in the first place. And again, they're for long-term control, not acute rescue.
And Zafirlukast has a really important dosing rule, doesn't it? Something that can make or break its effectiveness.
It does, and this is where adherence is everything. Food significantly decreases the bioavailability of Zafirlukast.
So it won't be absorbed properly if you take it with a meal.
Not at all. It has to be administered on an empty stomach. That means 1 hour before a meal or 2 hours after. That instruction is crucial for the patient to get the actual therapeutic benefit.
Got it. Okay, let's quickly touch on a few specialized agents and lifespan considerations. First, a very specific drug for critical care. Lung surfactants, like Baractant.
Yes, this is a drug for our tiniest patients, newborns with Respiratory Distress Syndrome, or RDS.
What's happening in RDS?
The baby is born without enough natural pulmonary surfactant. That's a substance that acts like a lubricant to keep the tiny alveoli from collapsing. Without it, they stick together and gas exchange stops. Baractant is simply a replacement for that missing surfactant.
And the administration is really technical, right? Straight into the trachea. What's the one key nursing detail there?
The procedure is an emergency. You suction the infant right before to clear the airway. But then, and this is critical, you must not suction for 2 hours afterwards unless it's absolutely necessary for survival.
Why is that?
You have to give that precious surfactant time to spread throughout the lung and do its job. If you suction it out right away, you've defeated the whole purpose.
Okay, and just to round things out, there are two other specialty agents to mention.
Right. Roflumilast, which is a PDE4 inhibitor used to reduce COPD exacerbations. It helps with inflammation, but it is explicitly not a bronchodilator. And then for idiopathic pulmonary fibrosis, or IPF, we have newer agents like nintedanib and pirfenidone that work to slow down that progressive lung scarring.
Great. So let's wrap this all up by thinking about age. How does the risk profile for all these drugs change between children and older adults?
For children, anti-asthmatics, especially those leukotriene antagonists, are very effective for long-term prophylaxis. The main risk here is really just about teaching parents how to accurately measure liquid forms to avoid accidental overdoses.
Simple, but critical. And for older adults, I'm guessing all those systemic side effects come back into play.
They come roaring back because older adults often have other issues, cardiovascular disease, maybe decreased kidney or liver function. They are much more susceptible to sedation, confusion, dizziness, and dangerous cardiac effects.
So the rule is start low and go slow.
Always. You start with a significantly lower dose than for a younger adult, and you monitor them diligently to prevent toxicity.
So to recap, we've covered the two main goals: bronchodilation with Xanthines, Sympathomimetics, and Anticholinergics.
And then reducing inflammation with the steroids and leukotriene antagonists for maintenance.
The key takeaways seem to be that narrow therapeutic window of theophylline
The absolute necessity of combining LABAs with steroids.
and the vital role of patient education and adherence, whether it's rinsing your mouth or taking a drug on an empty stomach.
That's the core of it.
So let me leave you with a final thought, a little clinical puzzle to bring all this together. Imagine a patient gets 2 inhalers to take at the same time: albuterol, a sympathomimetic, and ipratropium, an anticholinergic. Knowing that albuterol works by directly stimulating the airways to open, and ipratropium works by blocking the brake on airway constriction. In what order should the patient take those 2 drugs to get the absolute maximum therapeutic benefit, and why? That's what you can take with you as you think about how to apply this knowledge.
A fantastic test of understanding the different mechanisms at play.
Thank you for joining us on the Deep Dive. We'll catch you on the next one.